CEO of AMA WA. Welcome to our webinar series. Tonight, we are proud to partner with MDA National to bring you the medical legal questions during COVID time. Tonight, Andrew Miller will be joining us a little bit later to take over from me, but in the meantime, we really appreciate all the questions that you have actually put in during the registration, and we'll endeavour to actually go through them as much as we could. Just a bit of housekeeping. This session is recorded, and you will be able to actually revisit this at our website a little bit later. Other than that, during this webinar, you can also be asking questions. You can press on the Q&A button. For those who haven't used Zoom before, you might need to hover your mouse on the screen a little bit, press on the Q&A button, and actually type in your questions. We'll endeavour to actually answer them as much as we could, but we may not get to all of them on time, but we'll try to get back to you. So to our speaker this evening, we've got Dr. Jane Deakin, one of the medical legal advisors at MDA National for the past 14 years. She's currently the manager of the Medical Legal Advisory Service, but she has been a general practitioner and has run her practice in northern suburbs of Perth for many years and continues to be practicing part-time. So welcome, Jane.
Thank you, Benny.
So the way that we'll do this tonight is that we've grouped all your questions together, and there are some themes that we will try to actually get through. There's a lot of interest in telehealth. There's also a lot about work-related COVID issues about your rights as a doctor and the practice. And then there's some questions about personal protective equipment. So we'll try to cover them in themes. And so the first question, Jane, there's a lot about bulk billing and telehealth. So can the GP actually initiate and bill for a phone consult if there's sufficient complexity? In fact, there's a lot of questions that start about the government policies, whether GPs are being forced to actually bulk bill telehealth items. Your views and thoughts on that?
Well, first of all, can a GP initiate a telehealth consultation? And the answer to that is yes, if there is clinical reason for it. So if you've got a patient, for instance, who has an abnormal test result, then you would want to set up a consultation to talk to them about that. And in the same way, it could be a face-to-face consult, but you could suggest that it would be suitable for a telehealth consultation. So yes, it's not imagined that you will cold call your patients, but if there's a good clinical reason for that, then yes, you can initiate a telehealth consult.
That is a big difference in practice for a lot of GPs who normally have people just walking in, isn't it?
Yes, although hopefully patients are walking back into GP surgeries after some initial reluctance when we were all very worried about COVID. But I think numbers are picking up in GP surgeries. With regards to bulk billing, GPs are obliged to bulk bill vulnerable patients, and there's quite a list of those depending on their age, chronic health condition, parents of children under 12 months, people who are pregnant, and so on.
I guess this has been running for 2 to 3 months, and I understand that the criteria initially has actually changed a lot, but in the last few weeks, things have become clearer on those criteria, and I know that the definition of vulnerable patients is a little bit clearer.
Yes, the rules were changing every week for about 3 or 4 weeks, which certainly kept everybody on their toes.
Yeah. Jane has told me that she has actually fielded a lot of a lot of questions regarding telehealth. So we are going to utilize your expertise as much as we can tonight. So other than GPs, obviously other specialists can also do telehealth items. So can you actually share with us, about the risk management and the safety planning limitations, and also the medical legal obligations during telehealth consult? Perhaps there's even more, something a little bit different for a specific specialty like psych. What are your thoughts about that?
Okay, well, yes, we've got a lot of information about this. We have a lot on our website, actually, so I'll go through some of it, but there is more details and very useful links on our website. So like everything in medicine, really, preparation is key and patient expectation is very important. So when you're thinking about setting up telehealth, you need to think about your physical setup, and it's generally recommended for video consults that you have two screens. One where you're going to see the patient, and one where you're going to look at the medical record and be able to take some notes. You need to think about lighting so that the patients can see you, and you might think about your software. So for the occasional video consultation, it is probably acceptable to use something like Zoom. But if you're going to be doing it regularly, most doctors will invest in a commercial product which is more reliable and has better security. And again, we've got a link on our website about choosing a suitable product. Then you've got the situation where preparing your patient, because of course a video consultation is a new experience for patients, although many of them have now been using Zoom to catch up with their family and friends, but it is a new thing for most patients. So preparation of the patient, and there are some useful resources for that, and that might be provided by the receptionist when the appointment is booked, might be on your website, and you need to go through a bit of that housekeeping when you first get the patient on your video telehealth consult and you're ready to go. So you need to confirm that it is the right patient. Because normally in your rooms, the patient will identify themselves, of course, to the receptionist. So you need to do that unless you recognise the patient because you know them well. You need to ask the patient whether there's anyone else in the room, and if there is, whether they want them to stay or leave, and if they're going to stay, get them to come into view with the camera so that you can see them, and you may need to interact with that person. It might be a parent or daughter or whoever that is. You need to get the patient's phone number and tell them that if your video technology fails, you're going to call them up on the phone, so they're prepared for that. And talk a little bit briefly about the limitations of the telehealth consult, that it's not quite as good usually as a face-to-face consult because you don't get that interaction, and that of course some consultations will turn out not to be suitable for a telehealth consult. You might get partway through the consultation and realise that you need to examine the patient and it can't be done in this forum, and they're going to have a face-to-face consultation. And you might need to go over financials with them. If you're bulk billing, that's fairly straightforward, but if you're raising a charge and there's going to be a gap and a bill and things like that, then that needs to be discussed with the patient as well. And then you can get on with your consult.
Yeah. Just on the, you mentioned a little bit about the platform. In terms of note-taking, do you actually have to write down what platform was used? Do you have to show proof, just for record one day, whether it's Skype, whether it's, Zoom, whether it's WhatsApp, any particular requirement there?
If you're using a variety, and it varies from consult to consult, it is a good idea to jot down which platform you're using. If you've invested in a platform and you're going to do all your consults with that particular software or platform, then probably just if you make a note that from that date, all video consults were done with XYZ platform. And you don't need proof that it was done. If you choose to do a telephone consultation, it is a requirement that you note down why you didn't use a video consultation.
Oh, right. Okay.
So there's more documentation to go through.
Okay. How do texts come into play? You know, telephone, video. You know, if there's kind of a follow-up kind of communication afterwards, you know, what are the doctor's obligation on the text side of things if you start doing that with patients?
Do you mean texting? Or?
Yeah. Are you, because some of the platforms obviously allow exchanges, you know, like this, where Zoom, you know, suddenly someone actually can ask a question and you may answer, do copy and paste across to the notes.
Well, it's the same as if a patient emails you, you need to make a copy of that interaction in the patient's medical record, and you can't charge for having a text conversation with the patient. Well, you can charge, but you can't charge Medicare.
Yeah, okay. Just talking about charging, Jane, can we charge a telehealth item if we speak to a family member on behalf of a patient? So let's say like a daughter of an elderly patient. What's the what are the rules there?
It's the same as a face-to-face consultation. You can't bill Medicare if you don't actually have the patient with you. So if you don't have the patient and the daughter, if you have the patient and the daughter with you, then that's fine. You can talk to the daughter and the patient's present and you can bill Medicare. But if you only have the daughter, you can't bill Medicare.
Okay. I suspect that that is actually more often than, yeah, that crop up actually more often now than people think. I've certainly heard of a few of those queries in AMA. How about independent medical examinations and telehealth? Is that legit? Is that something that you know, medical legally work cover? You know, do they cover that type of consultations?
Well, I don't know what WorkCover's views are on that, but in general, I would say that some IMEs would be suitable for telehealth and some wouldn't. And I'm thinking that psychiatry could well be suitable, but obviously assessing someone with back pain, probably not. And I see that Andrew's joined us.
Hello, Andrew.
Hi all, sorry to be late. I'm hoping that this connection here is giving you reasonable audio and at least people can see that I'm a real clinician by running late just like everyone else. Thank you so much. And I have been listening in for the last few minutes. Have we seen anyone come a cropper yet, Jane, in terms of complaints? Are we starting to see a shift in advisory stuff at all yet, given the recent, you know, huge expansion of the telehealth consults?
Look, we are seeing some complaints that are related to telehealth and COVID. I haven't seen any so far that have had much substance to them. We've had complaints from patients where the telehealth consultation has begun and then the doctor has realised that they need to see the patient face to face, and the patient hasn't been too happy about that. So,
what are the sort of general situations where you think doctors should draw a line in the sand and say, I mean, I think most people will have their own kind of threshold for that, but with these some of the more entrepreneurial models out there where they're talking of, you know, they're trying to do pretty much everything online. Are you seeing grey areas yet?
Not so far, but I think that's where the problems are going to arise, because not all telehealth, not all presentations are suitable for telehealth. And, you know, someone with abdominal pain, headache, weakness, neurological symptoms, there are all sorts of things where you really need to see that patient face to face and conduct a proper examination.
Sure, and there's also been a bit of controversy over the years about in face-to-face consultations about the recording of them. But obviously the potential is there for either party in this situation to record it, potentially without the permission of the other person. Is this something that's going to simplify or complicate the medico-legal situation?
Well, I don't know. Doctors do get requests from patients to record the consultation, and sometimes that can actually be quite helpful, and the doctor may want to agree, and then the patient can play that back later to family members, and it may be of assistance. But if the consultation is recorded without the doctor's knowledge, it's my understanding that that can't be used later in legal proceedings, but you probably know that better than me, Andrew.
Well, it's a bit complicated because I think there is legislation that says you certainly cannot record it on the computer, but you may be able to record it with another device, which isn't interfering with the carriage service. So I suppose it also depends on what the doctor's done as to whether it's likely to be useful evidence down the track. So how egregious the doctor's behaviour is, how abusive they are towards the patient, if that can be substantiated with what is potentially a possibly slightly illegal recording. I know in occupational disputes around dismissals, that sort of evidence, they've said, well, actually the importance of the evidence is worth more than the technical infringement here. So I think more than ever, doctors are on a hiding to nothing if they stray off what it would be considered reasonable behaviour, and it does get recorded by someone. And there is this area around children, around the sort of 16-year-old kind of age group, and I suppose that's a bit like the elderly parent. They should really be present, shouldn't they, if there's discussion going on?
Well, for little kids and talking to their mum and dad, yes, the child should be present in the same way they're present for a face-to-face consultation. If people are thinking about 16, 17-year-olds and thinking that they might want to discuss something without their mum or dad being present, then I think that should be handled the same way as you would in a face-to-face consultation. And that is to say, it's my usual practice to offer young people this age, whether they'd like to see me on their own or not, and just to see what kind of reaction you get from the young person and the parent. And then if the young person wants to see the doctor on their own, that could either continue with the video consult if the parent's left the room, if the young person is happy with that, or I guess they could come into the surgery and see the doctor on their own if they prefer.
Sure, and I imagine this is something that will be of great appeal to the iPhone generations, in terms of convenience and so on. So what's your personal view outside the medico-legal aspects of the likelihood of this maintaining a big chunk of general practice consultation time going forward?
Well, I think patients love it, and I think a lot of doctors are finding it very useful as well. So I think it's going to be hard for the government to wind it back. What do you think?
I agree. I think the September 30 end date is a very ambitious way to have put these items out there. I think people have had a taste of freedom, and I think that inevitably the government will try to reduce cost by slashing away at the rebates as time goes by, because I think what it's going to do is meet an unmet need in the community. So people who hadn't previously bothered to get consultations, if it's convenient, they will. So that queue theory won't be operating. We have a question about an unsigned referral from the GP for imaging, where the patient's done it through telehealth. So how's imaging and pathology working? Do we need to set that up by communicating in another way with the X-ray and pathology providers?
Yeah, it's my understanding that those forms should still be signed, and that can be done in the doctor's surgery, and those forms sent to the pathology or X-ray place, or the patient can pick them up from the practice. So usually it's handled that way.
Okay. All right. Well, thank you for that. We will continue to take questions on telehealth stuff, but there's also been a registration of things around COVID, obviously, which has been a major revolution in our lives, and caused a lot of fear and anxiety initially, quite rightly, I think. And I was wanting to ask you at the get-go, one of the things we were concerned about was practitioners who manage a practice, own their own practice, what's their responsibility with regard to protecting patients in their waiting room and their staff from patients coming in with a fever who in a situation where there is community spread of virus?
I've had discussions with several practices about this, and different practices are managing this in different ways depending on their size, their facilities, their demographics. So a lot of practices are trying to separate potentially infectious patients from the non-infectious patients. And that might mean they have a dedicated room and entrance, and patients wait in their car and come into that spot, and the rest of the practice is dedicated to the non-infectious patients. Some of them split the day and are seeing regular patients up until a certain time, and then they see the potentially infectious ones, and then the practice is thoroughly cleaned overnight. Some practices have elected not to see potentially infectious patients, and that's been the case sometimes for very small practices that perhaps have a very elderly demographic who are very fearful about coming to the doctors. In all cases, the doctors have to make suitable arrangements if the patients can't be seen at their practice. But yeah, different practices are handling that in different ways.
So the responsibility of the doctor, as I understand it, probably resides in the code of good medical practice around what to do if you can't look after a patient who turns up to your front door, which is to politely arrange something else for them. What might that look like if you've quite reasonably made the decision that your facility does not have a separate room or a separate entrance or another waiting room where people can be effectively distanced, or you're a practitioner who doesn't have, who has your own health vulnerabilities, which applies to a lot of GPs, and you may not be in a position to personally put yourself at risk. So what does it look like in terms of what you do for people who just front up at the door as opposed to long-term patients?
Well, I think the first thing to do is try to stop them from fronting up the door. So patient education, website, something on your website about how you're handling it. Your staff have to be giving that suitable message, notice on the door, all of that. It probably still won't stop the odd patient turning up at the door. And then, look, you just have to handle that as best you can, taking into account your safety, the patient's situation, how sick they are, you know, what your local facilities are. So there's not an easy answer for that. And we have had a number of complaints from patients who didn't like the arrangement at that particular practice. So again, I don't think those complaints had much substance, but it's always difficult for patients to cope with change.
Absolutely. I find it difficult to cope with change, so I can't imagine what I'm going to be like when I'm a curmudgeonly elder gentleman trying to get into my general practice. And in terms of referring them on to emergency departments, that will be reasonable and possible for some people. For others, they may want to be familiar with which GP practices are taking patients and have a friendly relationship with them, because some GPs have obviously been keen to see these patients and have the system set up to deal with it. What about the situation towards your staff? If you're in an occupational practice sense, is it if you're not able to provide them with PPE, for example, are you getting an increased liability on the practice side there?
We haven't had any particular complaints or cases along those lines, and I think most practice owners are being very careful of their staff safety with distancing. Some have put up screens. The patients aren't allowed within 1.5 or 2 metres of the reception desk. They've cut down on the number of patients that can wait in the waiting room. There are a number of aspects that practices are doing to protect their staff. And of course, some staff members have particular health concerns, and some of them have been off work or redeployed.
Yeah, it's certainly been an interesting time, and one in which we ended up dealing with a different set of problems to the ones that we thought we were going to have initially, when we thought we were going down the path of big community numbers. And hopefully we'll be able to get a lot of information out of the UK and the US to see how family practice there, because there's not much of that coming through. There's a lot of hospital data coming through, but I'm not seeing a lot of the community medicine data around how things are being handled. So the sensitive handling of people, and you know, being careful to not just turn them away but to make sure that they have an option seems to be the best idea. And there are, of course, flu clinics which will be coming and going, but none of them are getting a lot of work at the moment. So I'm not sure how long those are going to be sustainable. I'm not sure, just returning to the telehealth assessment there, would it be feasible to do almost an emergency telehealth consult with people on their phones if they're trying to get into the practice? Yes,
and that can happen. You know, a phone call from the doctor to the patient in their car, in the car park, to try and sort out what is happening. Are they, you know, suitable to come into the practice? What's the best arrangement for them? Yes.
And you may have covered this before I got here, because my patient was continuing to have their operation somewhat inconveniently, but the doctor can initiate telehealth.
Yes.
Yes.
It's the same way as a doctor would initiate a consultation for follow-up of results, or to check on what's happening with the patient. You can't just cold call any old patient to suggest that they have a telehealth consult, but if there's a clinical reason for them having a consult, yes.
Yeah. There is a sort of relatively clinical question there along PPE guidelines, which is, and it's been an interesting evolution from the AMA's point of view, watching the clinical guidelines for PPE as they unfolded. Of course, initially there was a lot of fear that we would be seeing highly infectious, large numbers of highly infectious patients, a lot of shortage of PPE, very little being able to be handed out by the PHN, and coming on the back of bushfires, although which depleted all our masks. The interesting flip side to that coin that's been brought up more recently in the literature is that maybe the bushfires saved us because they also depleted all our Chinese tourists at the same time as they depleted all of our masks. And it may be that our outbreak was delayed as a result of a big slide in tourism, international inbound tourists during those few months. But from the AMA's perspective, the question is around office-based consultation of whether you need to be wearing masks and gloves, which is droplet precautions as opposed to airborne precautions where you're going to the respirator type masks, which we would not expect except in ICUs and invasive situations to be required. And I think our position on whether masks and gloves are required for standard consults is that that's an aspirational standard, where if there's PPE available, particularly if the doctor has any health vulnerability themselves, and particularly if the patient has any illness, then on the spectrum it would be good to have that available for particular consultations or for particular healthcare practitioners. And we think that that's where it should go to. But the national standard at the moment, which does take into account resource shortage, so we think that that is outdated, is very much a minimalistic standard that says no, for standard speaking to people, you don't need to use the droplet precautions. Are we seeing medico-legal battles breaking out around the use of PPE or conflict between practitioners, Jane?
Probably we took some calls early on in this from practitioners who were concerned about their own particular health vulnerabilities to COVID and wanted to wear PPE in the hospital, and the hospital had said no. So that was an issue that arose early on, and I'm not entirely sure, you probably know more than I, how that ended up, although everyone has calmed down a bit as there is very little community spread or no community spread in WA, and we don't have many COVID patients.
Yeah, I think that the situation is relatively stable at the moment, but what we're strongly advocating for is a revision of the PPE guidelines in this sort of hiatus period that we've got. So if we are dealing with outbreaks, which I think we all expect to at some point, I think Beijing's a bit of a salutary lesson. They're starting to walk into their outbreak at the moment, having been relatively spared the first time around. So I think we want to get in place something a lot more aspirational. There's a two-page hypothetical question which has come through about our legal obligations towards a patient where we are unable to contact them for a booked telehealth appointment. And I think this is a reasonable point. What is our duty to follow up if we had a telehealth appointment where we couldn't contact the patient?
Well, I think it's the same as if well, a little bit similar to if the patient doesn't turn up, though the reason for them not being on the telehealth consultation might be some technical IT thing. So, excuse me, I guess it would depend on what you knew about the reason for the consultation. So if it was for follow-up of an abnormal result, of course, then you would be trying very hard to contact that patient and get them for another telehealth consultation. I guess if they just booked one and you didn't know what it was about, then you could communicate them with them somehow via email or text to say, you know, you missed your appointment, would you like to make another one? So it would depend on the situation. And
I get in this scenario that's been carefully crafted here, the patient has an adverse outcome down the track. I suppose, would it be fair to say that if a patient has a catastrophic outcome or a bad outcome, they will often start looking for someone to sue, irrespective of the reasonableness of the initial attempts at contact?
Well, that does sometimes happen, yes. So it would always turn on the individual circumstances as to why they didn't get the telehealth consult, you know, and what the doctor knew about that. So it's a bit hard to say for sure how that would play out. It would depend on the circumstances.
Yeah, and the amount of information the practice had and all that sort of thing. You know, there is the famous, I think it was a Queensland case of a patient who contacted a practice with a headache, and the court found that the practice, from immediately knowing that, the practice does have a duty towards the patient. So the law tends to be fairly generous towards finding that duty is there. It may not necessarily follow through and say that you're responsible for everything that stems from there, but certainly when there's been some kind of contact, a relationship is established. So I think that that's where staff training and so on is very important as well, and we need to know within our systems if those kind of appointments are being missed and not followed through, particularly to say in the context of where there's been things investigated before. Getting into more of this sort of interaction between doctors and their staff and the practice, what should we do if we get to a situation where we don't have an environment that the doctor's comfortable working in, and they haven't got the PPE they want, or that objectively they need to do their work? And how should a doctor handle that situation where they're being put into a clinical scenario where they feel uncomfortable about their own safety?
Well, the doctor's safety should always come first. And for doctors working in the public health system, their employer has a duty to provide a safe working environment. So they should be talking to the hospital. If you're in private practice, doctors have more control over their environment and can decide what they want to do with a particular situation. But have there been that situation arising in the hospital system here that you're aware of, Andrew, where doctors aren't being given the appropriate PPE?
I think that at this stage, It's mainly because the guidelines have not yet, although they keep promising it, they've not yet contemplated individual healthcare worker vulnerability.
Right.
So it's a one-size-fits-all situation. So, and it's purported to be dealt with by redeploying people and saying, well, if you have an immunosuppressive disorder or you're on, chemo or whatever, we'll just put you into a situation where you don't need PPE. The problem with that being that they're saying you don't need PPE for consultation, but this may then start to put the doctor under an awful lot of stress.
Yeah.
And we then get into the area of, well, you also have a responsibility for the psychological safety and the mental health of your workers as well. Yes. So it's a complex and evolving question, and probably one better solved in the end by negotiation than litigation. But I foresee in the jurisdictions where there has been death and devastation through the system, a lot of PTSD claims will be coming forward. And I think that there will be a lot of, and with a lot of economic hardship will come a lot of patient claims as well, which will compound the injury for the doctors who have waded in and acted in a heroic manner. There will be patients who will bring claims against these doctors because they themselves have had a bad outcome and have nowhere else to turn. And they will try and allege some deficiency potentially. And so I think we've got a couple of waves of trauma to follow the initial one, which is why obviously close the borders forever is not the official policy of the AMA. I'm quick to add, but it's a wicked problem if you get huge numbers of cases. How do you feel about the risk around delayed diagnosis at the moment with people avoiding doctors? Is this an emerging risk for GPs?
Well, I think it is. We're not seeing it at the moment because we're probably still in the delay part. And look, there's a lot of factors going on there. Initially, especially, I think patients were a bit reluctant to visit doctor's surgery. So some of the delay in diagnosis may come from the patient. They've had a symptom that they would normally take to the doctor, but they decide, that they won't worry the doctor and they don't want to go out. So there's going to sort of be that aspect. Some of our screening programs were suspended for a while. Breast screen was suspended, but that's up and running, and I think it was only not operational for a few months, but potentially there could be something there, whether it will make a difference or not. I hear that X-ray and pathology numbers were right down. I think they're starting to pick up again, but there's going to be some difficulties there. So some of it's going to be patient related. Some of it may be related to doctors if patients claim that they had a symptom or they needed to follow up and they couldn't get to see their doctor because the practice was closed because of some COVID related issue. So potentially, yes, and we'll just have to deal with each one as it comes along, taking into account the difficulties that everyone was working under.
And I guess we need to practice in a slightly different way for a little while with a lower threshold for investigation and referral, given that it's reasonable for us to know at the moment that there could be a delay in people presenting with symptoms they otherwise may have presented with earlier. Doctors will be aware that patients have gone through this period of time.
Yes, and I think there's also a feeling now that we better get on and investigate because there could be a second wave and there could be delays due to COVID down the track. People are now a bit fearful about a second wave.
Yes, which is why everyone's rushing to get everything done at the moment. Go out for dinner and get your hair done and everything else that you need to do in case we all get locked down again for a while. God forbid. In terms of the general landscape around medico-legal stuff coming into COVID, what was the claims experience like particularly for GPs?
What do you mean?
In terms of, were we seeing a heightened aggression from lawyers around Western Australia, or were we sort of coming towards the end of 2019? Was MDA sort of cruising along in its usual, coping with things pretty well?
I think we were coping with things pretty well. There are always some aggressive lawyers pushing their cases. I think that's been the situation more over east than in WA. But yes, look, I can't comment that much on claims. It's probably getting a bit outside the area where I work.
Fair enough. But in terms of the stress levels of the people who are in touch with you at the moment on the advisory side,
Yes.
how do you think the toll is going on the profession, and do you think people are making the decision to leave?
I did take some calls from doctors, especially in the early part of the COVID, who were planning to leave. Doctors who might be reaching the end of their career and of a certain age where they thought, well, I'm in this vulnerable group. I was thinking about retiring. I think I might go early and think about my health. So yes, we had that. We did hear from a lot of distressed doctors, and especially when we were getting so many changes every week. Medicare was changing the rules. It was a very confusing time for doctors trying to work out what to do, trying to get used to telephone and telehealth consultations, having to deal with their patients' anxieties. There are a lot of things going on for them. So I would say a heightened sense of anxiety amongst doctors.
Because it is our sense, I suppose, that there are a lot of, there's not a lot of people going into general practice at the moment. General practice has been under a lot of stress from all different directions in terms of the freeze and the requirements on it. So it's a bit of a concern that on the supply side, that the remaining GPs might be under a big workload and therefore face a bit of medico-legal risk from that perspective by trying to do the right thing by a huge number of patients.
Well, there's no doubt that GPs were at the front line for changes, anxiety. Their patient numbers went down and then they went up. So they've really had a lot to cope with.
Yeah, and particularly those out in the regions where they wear lots of different hats, as well as, supporting half the community in a civic sense a lot of the time as well. There's also a bit of a risk that our colleagues, and one of the questions that's come up in the chat is around some of our colleagues minimising the science around COVID-19 and perhaps promoting alternative type therapies. Do we see people who practice in the area of complementary medicine run into trouble frequently?
Fortunately, Andrew, not too frequently, but I am aware, without going into too many details, of at least one practitioner in Perth who was advocating some alternative methods for combating COVID. And
what sort of trouble do they get into? What avenue, is this something that the medical board actively goes out and investigates, or is it wait for patients to complain? What happens there?
Well, the medical board doesn't go out and look for trouble. They act on notifications. So in that case, the situation was brought to the authorities and there have been some difficulties for that particular doctor.
And are those difficulties because they're moving beyond the bounds of standard medical practice, if you like? Is it a scientific test, or is it a sort of kind of a conservative test? How do they work it out?
That particular case, the practitioner was advocating some very unscientific things.
Right. Okay. So it'll be a fairly clear-cut one.
Yes, it was.
And given that you do deal with a lot of APRA style stuff, what's your advice around how nervous people should be about when they get that letter from APRA? How are you finding the sort of process at the moment?
look, for most doctors, it's their worst nightmare to get a letter from AHPRA, and we never underestimate the stress that puts on doctors. Fortunately, most of the notifications are resolved with no further action. So that would be more than half of them, because anybody can complain about anything and a lot of complaints have no substance. But that doesn't mean that the doctor's not going to be extremely stressed by the process, of course. And then we get complaints where there is a bit more substance to the matter, and then we assist the doctor through that process.
And would you say that the process is different for those who have an impairment? So if you have a mental health issue or an addiction issue, is that handled in a different way to those who have a complaint about a delayed diagnosis?
Yes, the AHPRA may put that doctor into the health stream and ask them to undergo a health assessment, and then they may put some conditions on their practice to enable the doctor to return to practice safely. Might be restricted hours, might be restricted scope of practice to protect the public.
And is it something that's handled with a degree of discretion? Because what a lot of people are concerned about, I think, is reputation and people talking about them as much as the effect on, and the effect on their family.
Well, the notification process, that's a confidential process. So if a doctor gets a notification, usually they will be the only person who knows about it. For an impairment matter, if the doctor gets some conditions on their practice, there may be something on the website, although some of the conditions that relate to personal health information is kept confidential. And of course, if a doctor gets an adverse outcome, then there may be something on the register, in the AHPRA register, about, you know, conditions or an adverse outcome. But it is a very stressful process, and AHPRA are a very bureaucratic organisation who go through a particular process, and there doesn't seem to be much humanity in it.
Which is why it's very important that we have humans like you looking after us in the midst of all of that. And if people need advice around how to set up their practice in a way that is going to be less likely to cause problems for them going forward, what does the MDO offer in that sense?
We're very happy to hear from doctors who are setting up their practice and want some advice about processes and systems. We had a call this week about a specialist going into practice, and they had a question about the note system and how that was going to be handled within a group practice. And so very happy to provide advice on that, because we also get difficulties when practices split up and who gets the records and how that's handled. So yes, we're very happy to hear from doctors who are setting up practice who want some assistance with aspects of practice management, privacy policies. We've had Support in Practice go out and talk to doctors about how to handle Schedule 8 drugs, how to improve their immunisation systems to decrease errors in that area, all sorts of things.
Okay, well, that hopefully reduces some of the stress and avoids the interaction with AHPRA down the track. There's an interesting question that's been posed by one of the attendees, circling back around to COVID and borders and travel. I suppose there's a bit of the interesting thing for me is the amount of politics that's been mixed in with the scientific response to this. And the AMA has been calling for 20 years or so for there to be a CDC in Australia, and we were sort of on a bit of a moral high horse with that one and saying the politicians should be kept out of it. Unfortunately, CDCs in other countries haven't been covering themselves in glory at this time, because I think largely because of political interference. In the case of the US, Singapore's CDC's done a very good job, although they did have a bit of a blind spot around their migrant workers. But the border discussion does seem to be getting caught up in a bit of politics and a bit of unnecessary beating of chests at the moment, in my view. I think that we're a lot like New Zealand in Western Australia, and in the way that we've gotten down to very low levels and seemingly no community spread.
Mm-hmm.
And they're talking about the idea of a passport for people to move in and out of the state. A passport in a COVID sense, which to make sense scientifically is talking about some sort of evidence of testing or some sort of evidence of antibodies, if antibodies do confer immunity or some period of time. And the problem with it all that we can see so far, including the football and everything else, is around the issue of still the incubation period and what you do with people who have a negative test on arrival. Do you still have to isolate them for 5 days or for 10 days or for 14 days to be safe? And so that's, I think, the reason why the Chief Health Officer in Western Australia is still got his foot firmly put down. And I think the sense of what I'm hearing, just so people hear the same rumours that I hear, is that once the July school holidays are out of the way, if nothing has changed with community spread around the country in a major upward direction, we're probably looking at relinquishing the hard border at that point, allowing some tourist travel to come in, some discretionary travel from there. Although it's been pointed out, the border's hardly closed at the moment. It's still quite porous, including internationally, with quite a few people still coming in to go to hotels. So just to cover off on that question, sorry to monologue a bit there, Jane. I was going to ask you, in terms of, I'm hoping that MDA hasn't had to get involved with the emergency powers of the Chief Health Officer and the Public Health Act and its penalties that apply to practitioners, because famously we've all been threatened with a $20,000 fine for ordering a COVID test on an asymptomatic patient. You've not seen anyone fall foul of that, have you?
No, I haven't. I thought they'd relax that though. No.
I think they haven't relaxed it from the point of view that there's no other lever that they have to pull. It's a shotgun or nothing. So they've decided to take a very controlling approach, and they did launch the Detect trial to look at asymptomatic groups, and that's been fairly heavily, scripted and controlled. So and whenever we've raised this and the inappropriateness and the offensive nature of telling doctors you're going to get possibly fined $20,000 and the lab might get fined $100,000 for doing the test, when the government didn't pay for the test in the first place, it really has started out as a resource shortage argument for this notice to be given under the Public Health Act, which is how all of these things are imposed under the law. And has ended up really, I think, being a bit of government and bureaucratic control, just trying to direct the testing where they think it should go, without really appreciating that there are large groups of the population, such as the mining companies and so on, who could probably just get on with testing without too much government interference or needing to be part of a research study. So we've covered off on our questions, where a lot of them are around telehealth there, a lot of them also touching on COVID. Jane, was there anything else that you thought that we should cover in the last couple of minutes, just to be sure that people are aware of their medico-legal obligations around this tricky time?
Well, first of all, I'd say to check out our website. We've really put a lot of work into some FAQs, and there's a really excellent telehealth toolkit with a lot of resources and links for people who are thinking about that. And I would say, in general, the same principles apply with telehealth as face-to-face. Patient safety always comes first. Well, doctor's safety comes first, and then patient's close second. So always think about the patient and apply the same principles for telehealth as you do for face-to-face.
Okay. Well, I'd like to thank you very much for your empathetic expertise and the support that you give to doctors. And I'd encourage people to follow up on that information with questions to us, and we'll pass them on to Jane and to MDA to answer. A lot of resource there on their website. The AMA is always available to answer your questions as well. We're very...
Just wanted to say, for particular questions, of course, MDA members ring us. You know, we're always happy to take phone calls and answer questions and assist with whatever's going on.
Yep. And for future members of MDA, you can contact your own insurer at the moment, but Jane's, of course, there for you should you change down the track. But we, as a West Australian medical community, I really feel that we pulled together. I think it's been a very cohesive, supportive time. It's been a very interesting time where a lot of people have made adjustments to their practice and decided to slow down a bit. It's also an interesting time because the bureaucrats are trying to reposition things within the state health system, and we're not sure how that's going to pan out just yet. There's moves to reconfigure Bentley Hospital are sort of going on in the background of all of this, and we know that King Edward's still a bubbling cauldron over there as to the future of what's happening there. So we're very active in keeping an eye on all of that. And of course, the other medico-legal issue that will be coming down the path that we'll have a chat about at some stage is the voluntary assisted dying, which is in the implementation phase. And all of my other spare time, apart from my spare time, is being taken up with meetings on that at the moment. So there's a lot of change going on, and I really think that I'm proud of the way the profession's responded here. Proud of the way the community's responded, so we didn't get a bunch of cases all at once. And so the problems we're dealing with are really, you know, the flow on of the economic and the social things. But I think there's a lot of optimism around that because we controlled the disease, we'll be able to go on and get back to just now doing the dance with the outbreaks rather than having to deal with all of the problems. So thank you so much for your time, Jane. Always a pleasure to talk to you. And always a reassurance to me that you're out there in the northern suburbs or at the NDA office when I need you. And thank you to all the attendees for giving us your time this evening to listen in, and to the AMA people for organising it. So we'll say good night for now. Thank you.
Good night.